I'm very glad after 3 years of housebound, and we are all here and meeting up friends, as well as so many doctors interested in this non-invasive surgery. My topic today is about focused ultrasound surgery, the potential direction in the future. And I'm going to share with you my own experience, which is quite new, but hopefully we can work together to advance the development of this surgery. When I look back, of course, like many of the surgeons here, and we started with open surgery, and of course some of the young people here, possibly they just started with laparoscopic surgery now. I hope in the future we are all starting out with just non-invasive surgery for our patient. So we have experience of open surgery, laparoscopic surgery, and focused ultrasound surgery. Now, I'm talking about this experience I have. As I mentioned, over the years, when we started with open surgery, laparoscopic surgery, and then get involved with more and more in laparoscopic surgery when it started. So I managed to get some award from societies, from the other colleagues. So I've written books on laparoscopic surgery. However, I started to change just a few years ago. Then I started to write book on focused ultrasound surgery. It was an unusual opportunity just in year 2017 when I attended one of the meeting in China. So this Chinese Medical Association annual meeting. I listened to the talk of Professor Wong and whom I met several years ago before this meeting. But I was impressed what he had presented about what he had done with the focused ultrasound surgery. No, so I visited Chongqing here, the old location, the site, Haifu, and learn about this so-called focused ultrasound surgery. They call Haifu. Now, I don't want to go into how it works and all that. I just want to share with you my thinking and my experience from a clinician point of view. So I got my colleagues from Hong Kong and also from Australia to visit this center. And I've written up our experience and want to make people interested about this type of non-invasive surgery. We learned the focused ultrasound surgery, and very interesting when we first learned, we don't know anything. We can't see anything. The images we consider as so poor. But later on, when you get used to it, you know what we are looking at. It's much better now. And thanks to the COVID, I was housebound and can't go to visiting other friends in overseas country. So I have time to write up all this book. There's 4 of them, and all involved with focused ultrasound surgery. I've written around 30 papers about my impression about focused ultrasound surgery, this case report on complication. Now, however, this focused ultrasound surgery is the thermal ablation. Even though it's non-invasive, it can thermally damage the surrounding tissue. That's why we have been very careful. And in our treatment plan, we plan how to avoid burning the damage or the surrounding tissue like bladder, bowel, and even ureters and all this. And it have the so-called the risk of heat injury. As you can see from various research, and the temperature can reach 1,000 degrees centigrade, but the heat can spread to the surrounding area. Even though we are talking about, yes, you are burning from one side to another and from one point to a line to a section, and then add it up together so that you can burn the tumor. However, in practice, we all know what happens is you try to avoid this thermal spread. That's why you are burning from the middle and the upper part, or more posterior part of the tumor first. That's our experience in fibroid. It might be different for pancreatic cancer or kidney cancer, but we do try to avoid the thermal injury. That's the problem of what we are doing, because we are not killing all the cells. And luckily, fibroid do have a capsule. That's why we may be able to, just like a oven, to burn all the fibroid tissue. But it might be different for cancer work. Now, even though we say, yes, we are monitoring it with grayscale change under ultrasound, we are using the color Doppler to see how effective we work and the micro bubble. And those on the floor possibly know all about this monitoring we are using. However, they are only used to see the results of what we are doing, how much of the effect we have done. But we cannot predict any injury to the surrounding area. We don't know how the heat spread will go to nerve, bowel, or bladder in front. That's why we end up with, even though the complication much less, and it's still some problem. Now, so the problem, I did mention, many of us will experience about that, like we need the skill and the technique. We need to learn how to study the MRI, the ultrasound imaging, and the treatment. Of course, in my center, it's a bit more expensive, and patient paying so much for the ultrasound, for the HIFU treatment, and they will have worry whether it work or not, because they hardly know anything about this focused ultrasound. When they ask other doctors, and like Professor David Cranston said, it may be conflict of interest, and they will not introduce this non-invasive surgery. Patients worry about that. And for us, there's limited application. We still have to use laparoscopic surgery or open surgery for many of our surgery. For us, we can use only focused ultrasound surgery for fibroids and adenomyosis. So some patients get recurrent and they come back and they say, well, how come? You say it's very good the result. The result is from the literature. It's good, but I got my problem. We come back now. So there are also complications, even though we all know it's quite low. My friend, Professor Wong, and I written up the book on focused ultrasound surgery on our benign uterine disease. And we did report some of the complications of other people's and all together to show people what can happen. For example, when the ovary is, when the uterus is burned too much, it hit the serosa, just like in the left side of the paper. And you see the fibroid and being burned, the uterus, the serosa being burned. So this patient complained of pain, laparoscopic surgeries were done, and we see the result. And we have patient, of course, the skin burn. Luckily nowadays, we control the skin burn, minimize it quite well with very precaution. And so it happened quite unusual nowadays. And now, we did like the pictures on the right side. When we burn a submucosal fibroid, sometimes the endometrial cavity being burned, it will not heal up. So these are the patients. Some are young, they want further pregnancy. That might affect their future pregnancy. The chance of getting placenta accreta is possible. So more commonly, a patient complain of still have or bleeding and also pass out some mass. I mean, these are the complaints. They are quite minor. There's no major life-threatening injury. And blood transfusion, no. And so these are very minor complications, but they still have patients still unhappy. And because they are new technique, one of the problems we encounter is some of the complications that come out, we don't know what it is. We know, for example, this patient, after I have ablated a large tumor around 12 centimeter, and the next day she developed all this hemorrhage. So petechiae, and on the surface of the skin, leg and arm, we check the blood is thrombocytopenic purpura. And she also have abnormal liver function test. Now, we clinicians, when we do surgery, we know what complication right away, but for HIFU surgery, since we clinicians have not understand the basic mechanism, how it works, we only know we burn it and then the cell die. So what will be next? What complication? Why there's decrease in platelet count and also abnormal liver function? So it's likely in my case report, and I suggest that it's because of the consumption of the platelet and because of the necrosis and the dying tissue, the repair. And this lady, in 2 days later, she recovered very well. It's still a complication, but not major, but we worry about it, could be other things. So we need to report all cases like that so that we all learn and will not be excited about that. This another patient with adenomyosis, I also report because she developed bilateral ankle edema. You can see the leg is swollen like that. She come back and we thought, could it be deep vein thrombosis? We hit some of the pelvic vein. Could it be other than deep vein thrombosis injury, other injury? For example, the nerve and all that, and causing the problem. Now, she have no deep vein thrombosis, and we don't know the answer at this stage. With my case report saying that it could be due to we inject GnRH, and before the surgery that might cause the increase in estrogen and deep vein thrombosis or edema, lip edema come up. So we still don't know the answer, and in 2 days' time, the patient, the leg recover. So these are the surgery complications we can't explain for the time being. So we need to learn more. Nevertheless, though there could be the heat-related complication. So we try to avoid damaging the surrounding tissue. We avoid the 100% ablation. So even 90% for big fibroids could be the cause of the recurrence. So science needs changes or need further development. So it's not like Charles Darwin said, it's not the strongest of the species that survive, nor the most intelligent, but the one that more responsive to changes. So even for focused ultrasound surgery, we need to make some changes. Our changes is, could we go into the direction of the non-dermal ablation? Now, of course, we all know from the urologists, they have something we call lithotripsy. That means the kidney stone using shock wave to blast the stone. So they're getting into smaller pieces and then pass out. Of course, using the soft wave, the patient did have bleeding problem, bruises, and discomfort during the treatment. Yes, also non-invasive, but their mechanism is slightly different, and they are using shock wave rather than ultrasound wave. So, unfortunately, for bleeding and all that could be a problem. Besides this, you break the stone, but whether you can do this with the fibroids and all that. But there is another possibility. We should know about the ultrasound, what effect they have done to the tissue. And histotripsy, not lithotripsy. So we are doing the tissue now using the focused ultrasound. It's still experimental, and so it generates the acoustic energy by the transducer, similarly ultrasound transducer, that focus on the tumor. Now, the concept is just like the short wave lithopathy. Now, in this way, then you can do the mechanical ablation of the tumor using ultrasound, performing the same thing, like mechanically break the tissue into pieces. Now, there's two mechanisms. One is the pulse ultrasound cavitation. So when the ultrasound hit the tissue, cavitation will form. So by giving high intensity and focused ultrasound by the pulse form, so you can create quite a lot of cavitation damage to the tumor. But to make it faster, you can use the ultrasound energy to get into a heat, so-called boiling histotripsy, up to 100 degrees centigrade. Now, in this way, so it might serve just like the short wave lithopathy. So the generally, the focused ultrasound surgery we are using in the histotripsy could be a generally short and high intensity burst of ultrasound wave that create tiny bubble. And in the tissue, when the bubble bursts, then that creates enough energy to damage the tumor. Now, just like the features, it's just like our ultrasound, but we are continuously, for the high focus ultrasound, we continuously, so we get the grayscale, we have more damage, the heat spread. But if you keep the temperature low and focus something point, you might be able to produce the effect. Nevertheless, it's just really have not been found working too well, especially in the clinical study. Now, this is the mechanism how the ultrasound work. The first is they focus on a point, the temperature is starting to rise to 40, 60, 80, 90, 100, and when it reaches 100, bubble will form. As a clinician, I'm thinking just like when you are boiling your water, when the water near 100 degrees, you can get the air bubble to coming out. So vapor will develop from a cell who have high water content. In this way, when the bubble starting to, under the pressure, will be expanding, oscillating, and when you further have more energy that focus on that point. Now that bubble, when it's getting bigger, and it can burst all the hot waters and all that, will damage, will heat up, and will destroy the surrounding tissue. This, as a clinician, that's my understanding of what can happen. So when you adjust your intensity, when you adjust your frequency, as well as the duration of the treatment, you might be able to modify the treatment of focused ultrasound by reducing the temperature spread. So experiments have been done with this kind of histotripsy equipment similar to our high-flow treatment. So the histotripsy treatment and the high-flow are different. One is very high intensity ultrasound, the other is high intensity only. Pulse energy or continuous energy, or mechanical effect that's just damage the tissue by mechanically without the heat. The thermal effect is the high-flow we are using. So it causes coagulation, necrosis, and the cellular, on the other hand, the mechanical effect will be cellular fragmentation, so the tissue damage. So roughly, the diagnostic ultrasound we are using is 1 to 2 watt per centimeter square. And the thermal high-flow we are using 100 to 2,000 watt per centimeter square. The intensity we use in histotripsy is 15,000 to 20,000. That's what I read from the literature. So the high-flow is thermal energy, while the histotripsy is using the energy causing cavitation and mechanically destroy the tissue. Since the cell many of the cells will survive. The immune response is good. So the advantages is that, again, it's non-invasive, hopefully doesn't have the thermal effect. Now, but the issue of this histotrypsin is still experimental, and for large tumor, you don't know whether it works or not. And the depth of penetration, the energy you use, even though it's high, but it's very short. So whether it can go into deep penetration, ultrasound can reflect and absorb by the interventing tissue, that is the issue. Now, recurrent, when we are talking about cancer, it's recurrent. It's terrible. So we don't want that. Palliative, yes, good, but it's not what we want. And we worry about what we are doing mechanically. It may spread the viable cancer cell to the bloodstream. Nowadays, we know that there's already circulating a tumor cell in the blood by advanced cancer. So what about this? Have we studied that? So it may take some time for this to recur. Now, I think I'm running short of time. I just mentioned a few things. Is the next thing to reduce the temperature is that the intensity and the focus, one point, use the mechanism of ultrasound electric field can open up the cell membrane so that cell and genes can go into, or drugs can go inside the cell to perform the function we want. It facilitates. This way, facilitate drug and gene development, delivery to the tumor tissue. And it's a promising technology, and in cancer work, in gene treatment, as well as vaccination. I think the Oxford team, under Professor David Cranton, already starting to do all this work with liposome. And hopefully, with the ultrasound that creates sonoporation, we will be able to enhance the drug delivery in the tumor cell. My group, also my friend in Sydney, we are trying to, instead of liposome, we are doing the nanoparticle, which he is going to present some of our study tomorrow. So the challenge of the sonoporation is similar to histopathology. The deep-sighted tumor, the large tumor, it can be a problem. So, however, there's more and more development in this field is that they use the ultrasound sonoporation, but they add on to it, for example, dual frequency ultrasound. You can ablate the majority of tumor, but for the others, tumor, you can deliver the drugs. And so dual frequency ultrasound. And we are also talking about what can we do, for example, like that. Can ovarian cancer, able to have the ultrasound stuck to the body, able to help us the problem of abdominal metastasis and all this. So hopefully all this development do not generate heat, are able to perform the ultrasound. So I don't want to go into the so-called liposome chemotherapy because Professor David Cranson and the team, and he have also mentioned about that. And these are the results that we hope will be able to deliver the liposome or nanoparticle that have drugs or gene encrusted into it. Now, as you can see, we clinicians do not know much about this kind of development, but will be hopefully our interest. We're excited to research the laboratory able to help us to achieve something we want. So we need to identify what our non-invasive surgery are still lacking. So we need to join force together with many of the university laboratory to deliver something we want to do. So I think there's still a lot of future in this focus ultrasound surgery. We are glad that we are starting to have the machine, the development, and also Chongqing. When I visited yesterday, I found that they are going to the same direction like everyone in the world reported in the literature. They are already doing it. So I'm looking forward to see in the next few years' time, and I'm still not retired yet. So able to see all the development. Thank you very much.